Namaskar everyone. Welcome back to the third lecture of our series of lectures on rehabilitation of sports injuries of the knee. Today, I shall be covering the clinical evaluation of the knee. As you all know, a thorough evaluation of knee involves a structured approach beginning with a detailed history and followed by a clinical examination done by inspection, palpation, range of motion assessment, measurements, and special tests. This is done to identify specific structures involved in the injury. A knowledge of anatomy, functions, and common mechanisms of injuries helps in interpretation of clinical findings. This helps us differentiate between ligamentous, meniscal, tendon, or other soft tissue injuries of the knee. Ultimately, the clinical evaluation not only establishes the diagnosis but also helps us take informed decisions on further investigations, management strategies, and explaining the prognosis to the patient as per his or her requirements. As discussed, the first aspect of clinical evaluation is a thorough history taking by inquiring about the complaints of the patient. Each complaint, which is also called symptom, is to be asked in detail as regards its mode of onset, duration of symptoms, progression over a period of time, any associated symptoms, any aggravating or relieving factors, and the present functional status of the individual. The common symptoms with which the patient can present to us could be pain, swelling, instability or feeling of giving way, locking or catching in the knee, inability to bear weight, and stiffness or reduced range of motion. All these symptoms need to be inquired in detail. As regards pain, which is the most common symptom with which the patient may present, it is important to note its site, severity, onset, progression, and aggravating and relieving factors. Next is swelling, which can occur immediately within minutes, and when it happens within minutes of injury, it is generally due to hemarthrosis, which indicates a ligament or a meniscal tear, or even a fracture. Whereas a delayed swelling, which can happen few hours or days after the injury, may indicate a lesser degree of severity of injury to the knee. When intra-articular structures are involved in the injury, the swelling is generally a generalized swelling, since the blood or the fluid that accumulates can spread inside the knee throughout the knee, whereas extra-articular structures, when they are involved, they generally cause a localized swelling. A feeling of giving way or instability generally indicates a ligamentous injury. Locking or catching suggests a meniscal tear or a loose body in the knee. Weight bearing, when it is affected, generally indicates the severity of the injury. The person may not be able to bear weight when there is a bony or a severe meniscal or a ligamentous injury. Range of motion may also be reduced, and this may be reduced either because of pain or due to the mechanical effects due to effusion or loose body or a damaged meniscus. Associated features like other joint pains or systemic symptoms like fever, weight loss, morning stiffness, etc. need to be noted. And if there are any neurovascular symptoms associated, also needs to be recorded. The functional impact of injury on the individuals, that is ability to perform activities of daily living like climbing stairs, walking, squatting, or their impact on sports or occupation also need to be recorded. Then you need to record the past history, if there were any similar complaints in the past of the knee, any surgery the patient has undergone, or any form of treatment the patient may have taken before coming to you. Any history of recurrent dislocations or instability of the knee need to be recorded. And additionally, any history of any chronic illnesses like diabetes, hypertension, rheumatoid arthritis, gout, and osteoarthritis also have to be asked. And since these other causes may have a bearing on treatment and prognosis of the injury. Then there are certain red flag signs which one needs to be careful about. Any open wound or bleeding indicates a penetrating trauma or a severe injury. Any inability to bear weight at all, even after a few days of injury. Any fever or swelling in the knee needs to be noted. Any locking of the knee. And these symptoms generally should alert the clinician about a more sinister nature or a more dangerous problem that may be lurking, and a quick diagnosis and a quick treatment may be required. After a thorough history, we proceed to the examination. The examination starts with inspection of the patient, and the patient needs to be appropriately exposed, and the examiner should be able to see the knee from all sides so that no finding is missed. Especially, this is true with the posterior aspect of the knee. Generally, people tend to miss out findings on the posterior aspect of the knee. The first thing that needs to be seen is the gait of the patient, how the patient is walking, whether it is normal or whether the patient is limping, whether the patient has an antalgic gait, or if the patient is using a walking aid to ambulate. If swelling or effusion is present, then whether it is localized or is it generalized swelling of the knee. If any deformity is present, that is inability to extend the knee, which is called a fixed flexion deformity or locking of the knee, may have to be noted. Any bruising or ecchymosis, if present around the knee, generally indicates subcutaneous bleeding, and its extent and resolution needs to be noted. Any muscle wasting, especially the quadriceps atrophy, which is very common after even a few days of immobilization, or due to limitation of knee movements due to effusion or pain. After a thorough inspection comes the role of palpation. The first thing that is need to be checked in palpation is the local temperature. Warmth around the knee when compared to the other knee generally suggests inflammation or infection. There could be tenderness around the knee. The common sites where you need to check for tenderness are the joint line. Joint line tenderness, generally medial or lateral, generally may indicate a meniscal pathology. A localized tenderness over bony prominences may be present, and it may indicate bony injury or injury to the collateral ligaments, the patellar tendon, the pes anserinus, which may be noted. Or sometimes the tenderness may be over the quadriceps tendon. Any effusion, if present, should be checked by the ballotability of patella or by fluctuation test. Any palpable gap in the collateral ligaments or patellar tendon or quadriceps tendon or even the muscles needs to be checked. And this gap generally indicates a frank tear. Next is the recording of range of motion of the knee. Both active as well as passive flexion extension needs to be checked. A restricted range of motion may either be because of pain or because of mechanical block due to an intraarticular loose body or effusion or a bucket handle tear of the meniscus, where the knee may be locked and the patient is unable to fully extend the knee. This is followed by the measurement of girth and the lengths. the girth of the thigh and calf muscle is important, since any injury to the knee may result in wasting of these important muscles. And as we have learned previously, these muscles which are around the knee, they act as secondary stabilizers or dynamic stabilizers of the knee. So any weakness in them is naturally it affects the stability of the knee. Lastly, the distal neurovascular assessment is done to see if the distal sensations are intact, if the distal pulsations are intact, and if there is any weakness in the muscles distal to the knee. It is always important to check distal pulses, sensations, and motor function, because in high energy trauma with multi-ligament injury, vascular and neurological injuries may be associated. Following this, we now turn our attention to the special tests done to detect any specific ligament, meniscal, or tendinous pathology. We start the special tests for the special tests for the cruciate ligaments. For the anterior cruciate ligament, the commonly performed tests are the anterior drawer test, the Lachman test, and the pivot shift test. Anterior drawer, it is done at 90 degrees flexion of the knee, where we pull the tibia forward as shown in the figure. A side-to-side difference is noted to see the amount of translation. A grade 1 laxity generally means that the translation is less than 5 millimeters. A grade 2 means it is between 5 to 10 millimeters. And grade 3 is generally translation more than 10 millimeters of tibia. This classification is common for any ligamentous injury. Another test for ACL is the Lachman's test, which is the most sensitive test to detect ACL insufficiency. This is done with the knee in 20 to 30 degree of flexion as opposed to 90 degree flexion in the anterior drawers test. Here again the tibia is anteriorly translated and the amount of laxity is noted and compared with the other side. Next is the pivot shift test. This test is done to assess the anterolateral rotatory instability of the knee. This can be done in supine or a floppy lateral position. A combination of axial load and valgus force is applied to the knee along with internal rotation of tibia. In this position, the knee is gently moved from full extension to flexion and vice versa. A clunk or a pop indicating a tibia subluxating or displacing anteriorly when moved to full extension and reducing back to normal position when the knee is flexed is seen if the ACL is deficient and is generally indicative of a ACL tear. After checking the integrity of ACL, the next common set of tests are performed for the posterior cruciate ligament. The quadriceps active test is done by flexing the knee to 90 degrees while the patient is lying supine on the couch. The patient is asked to actively contract his quadriceps, and from the sides, any anterior movement of tibia is noticed. If the tibia is subluxated posteriorly in cases where PCL is deficient, the moment the patient contracts the quadriceps, the tibia translates anteriorly and it subluxates back when the patient relaxes. And this is commonly seen in PCL tear. Next, the posterior drawer test is done. This is similar to how we perform the anterior drawer test. And instead of an anterior force, here a posteriorly directed force is applied to the proximal tibia when the knee is at 19 degrees of flexion, and similar amount of laxity is present and when compared to the other knee, indicates a posterior cruciate ligament injury. The other tests done for PCL include the sag sign or Godfrey's test, where tibial sagging is noticed when hip and knee are flexed to 90 degrees and the foot is held by the examiner. A posterior sag indicates a PCL injury. Now coming to the provocative test done for collateral ligaments of the knee. The valgus stress test is done for medial collateral ligament injury, and this is done at 0 and 30 degrees of knee flexion. A laxity in the medial collateral ligament or opening of the medial joint line at 0 degrees indicate that there may be a combined ACL and MCL injury, whereas a opening only at 30 degrees indicates a MCL injury, an isolated one. Similarly, a varus stress test is done for the lateral collateral ligament injury, and this is also done at 0 and 30 degrees of flexion. Laxity at 0 degrees indicate a combined LCL with a posterolateral corner and a cruciate ligament injury, whereas laxity only at 30 degrees of flexion indicate an isolated LCL injury. For the menisci, the commonly performed tests are the joint line tenderness, the Thessaly, and the McMurray's test. Out of these, the medial and lateral joint line tenderness is the most sensitive and most consistent test, and it can tell you the location of the tear as well, whether it is in the anterior horn, the body, or the posterior horn, depending on where the tenderness is. In the Thessaly's test, the patient stands on the affected limb and rotates where the knee is slightly flexed. A pain or click felt is positive. However, this test can be positive in many other conditions like osteoarthritis, osteochondral injuries, or ligamentous tears. Hence, not a very reliable test. Then we come to the McMurray's test, where flexion and extension of the knee is done while the tibia is either internally or externally rotated, and a varus valgus strain on the knee is given. A painful click indicates a tear, and when the click is appreciated with in a flexed position, it generally indicates a posterior horn tear. When it is appreciated in the middle position, it indicates a body of the meniscus tear, and when it is appreciated when the knee is almost in full extension, it indicates an anterior horn tear. For the patellofemoral joint, patellar apprehension and grind tests are commonly performed. In patellar apprehension or glide test, a lateral push on the patella causes apprehension, and this happens when there is a medial patellofemoral ligament injury or MPFL injury. In the patellar grinds test, or which is otherwise called Clark's test, pain which can be produced on resisted quadriceps contraction is indicative of patellofemoral joint issues like chondromalacia patellae. To conclude, systematic examination of the knee combines history, inspection, palpation, motion, and stability tests. These tests, when done carefully, help us localizing the pathology, whether it is in the ligament, meniscus, cartilage, or in any other soft tissue around the knee. This must always be correlated with the mechanism of injury and imaging of the knee, which we will be learning subsequently. An early accurate diagnosis, which you can arrive at if you do a thorough clinical examination, ensures an appropriate management and better outcomes. And it is important to note that the clinical skills generally improve with practice, comparison, and consistency. This brings us to the end of this lecture. I hope the clinical examination of the knee is clear to you all. Thank you and Jai Hind.